There is a quiet transformation that takes place within the human body once we cross the threshold of 60, and it almost always goes unnoticed. You might be taking the exact same prescription you've relied on for a decade, a pill that never used to give you a bit of trouble, yet suddenly it begins to function differently. The medication hasn't altered its formula, your biology has simply shifted, and the consequences of that shift are far from trivial. It can represent the invisible boundary between staying protected and facing sudden danger, a gradual, hidden accumulation of stress that elevates your vulnerability to a catastrophic event like a heart attack or a stroke. The real danger here is the absolute lack of drama. There are no sudden aches, no flashing red lights, and no obvious symptoms. It is a completely silent transition. Today, we are diving into 5 specific categories of medication that carry significantly higher cardiovascular risks after age 60, particularly when they are taken out of habit, without accounting for how your physical baseline has changed over the years. Before we go any further, let me be entirely clear. This discussion isn't meant to frighten anyone. It is designed to empower you with a deeper look into your own physiology so that you can navigate your healthcare with confidence. My name is Dr. William. As a practicing physician, my goal on this channel is to demystify complex medical concepts and turn them into actionable insights, helping you truly comprehend your internal health and what steps genuinely preserve it over the long haul. If this perspective resonates with you, feel free to subscribe, but more importantly, I urge you to stick with me through this entire breakdown, because one of the therapies we are going to expose is a daily staple for millions of adults who rarely stop to question it. To get a clear picture of why these health risks escalate after 60, we have to look at a fundamental truth that is rarely explained in a standard checkup. Your body simply doesn't manage pharmaceuticals the way it did in your youth. This is where the landscape shifts. As the decades advance, our internal filtration and metabolic systems naturally lose momentum. The liver, which acts as the primary processing plant for breaking down chemical compounds, operates with less speed. Simultaneously, the kidneys experience a decline in their filtering capacity, meaning they don't clear waste from your bloodstream quite as rapidly. Consequently, active compounds linger in your biology for an extended period, frequently far longer than clinical guidelines assume. When this happens, a standard, routine dosage can inadvertently begin to mimic the intensity of an overdose as the days roll on. But metabolic slowdown is only half the equation. Your vascular architecture is also undergoing a profound evolution. Your arterial walls lose their youthful elasticity and become stiffer. The delicate endothelial lining of your blood vessels grows far more vulnerable to microstressors. Your internal blood distribution alters, and the hypersensitive equilibrium between clotting and bleeding grows precarious. When you introduce a medication into this altered environment, its secondary effects can easily become amplified. This is precisely where patients get caught off guard. The drug in question isn't inherently toxic. In fact, it might have been the perfect clinical choice when your doctor first wrote the script, and it may still hold therapeutic value today. But the vital context has changed. Clinical medicine is entirely dependent on context. A specific therapeutic agent can be a lifesaver in one chapter of life and a liability in the next. A dose that was perfect at age 50 can easily become overwhelming by age 70. Yet, in the real world, scripts are routinely refilled for years on autopilot. This doesn't happen out of medical negligence. It happens because these biological changes crawl forward quietly in the background. Here is the crux of the matter. After age 60, your baseline statistical risk for strokes and cardiac events naturally climbs. That is simply the standard curve of aging. However, when you layer unadjusted medications on top of that elevated baseline, you can inadvertently push that risk profile much higher. It happens incrementally, hidden beneath the surface, showing zero outward indicators until a crisis occurs. That is why we need to have this conversation. We aren't just analyzing chemicals in a lab. We are looking at how those chemicals interact with your specific physiology right now, and identifying the practical steps you can take to stay safe. Before we break down our first 2 examples, I must emphasize a vital ground rule. Nothing in this video is an instruction to abruptly stop taking your prescribed regimen. That is dangerous and counterproductive. Our objective today is education. When you grasp the underlying mechanisms, you gain the vocabulary to ask sharper questions. You can engage in a true partnership with your care team and stop coasting on an outdated routine that is crying out for a modification. That brings us directly to the first tier of vulnerability. The initial two drug classes we will examine are staples of the modern medicine cabinet. They are taken around the world every morning, generally viewed as completely benign, yet under the right circumstances, they can quietly overwork the heart muscle, drive blood pressure upward, and compromise circulation through fragile pathways. Let's look at exactly how that happens. We will begin with an incredibly commonplace intervention: pills that people ingest habitually for years or even decades without a single pang of anxiety. Yet, past the age of 60, their internal behavior alters dramatically. First up are non-steroidal anti-inflammatory drugs, universally known as NSAIDs. This category encompasses everyday over-the-counter options like ibuprofen and naproxen, alongside heavy-duty prescription pain relievers. They are the go-to remedy for chronic back pain, stiff joints, arthritis, and general physical discomfort. To the person taking them, they seem like a flawless quick fix. You swallow a tablet, the chronic ache recedes, and you go about your morning. Deep within your tissues, however, a very different scenario unfolds. NSAIDs achieve pain relief by deactivating specific enzymes that trigger systemic inflammation. The catch is that those exact same enzymes are responsible for shielding your blood vessel walls and optimizing healthy blood flow. This is where the conflict arises. After 60, your arteries have already lost a degree of flexibility, and their inner linings are highly reactive to stress. When NSAIDs disrupt those built-in vascular defenses, it can prompt a subtle, sustained constriction of your blood vessels. This narrowing forces your blood pressure upward, not in a dramatic spike that alerts you, but in a slow, persistent climb. At the exact same time, NSAIDs alter how your kidneys govern fluid management. They signal your body to retain surplus sodium and water, which balloon your overall blood volume and force your heart to pump against a much heavier workload. You now have a dangerous double whammy: elevated pressure paired with fluid overload. For an aging cardiovascular system that is already working harder, this combination is a major burden. A vast body of large-scale clinical research confirms that the long-term or frequent use of NSAIDs carries a quantifiable spike in heart attacks and strokes for older demographics, particularly those with pre-existing risk factors. The trap lies in the immediacy of the relief versus the slow burn of the damage. You can't feel your blood pressure creeping up an extra point every week, nor can you feel the microstrain on your arterial walls. But over months and years, that structural stress compounds. To be clear, this doesn't mean NSAIDs are universally evil. It means they demand deep respect and strict boundaries. A brief course for an acute injury or occasional, well-monitored use can still be perfectly safe. It is the unexamined, daily reliance on them after 60 that opens the door to trouble. That leads us to our second category, which is even more insidious because its cardiovascular impact is thoroughly underestimated. These are proton pump inhibitors, or PPIs, popular acid-suppressing drugs like omeprazole and esomeprazole. They are broadly utilized to manage acid reflux, quell chronic heartburn, and shield the stomach lining, especially when a patient is taking other medications that might cause gastric irritation. On the surface, they seem entirely benign. They put out the fire in your chest, protect your stomach, and let you eat in peace. However, the cascading consequences are deeply veiled. Stomach acid isn't a design flaw. It is an absolute necessity for extracting critical micronutrients from your food, specifically magnesium, calcium, and vitamin B12. Over an extended timeline, the acid-depleted environment caused by PPIs heavily compromises your body's ability to absorb these nutrients. While a nutritional deficiency might seem distinct from a cardiac crisis, the biological links are direct. Magnesium is a vital regulator of cardiac electrical stability. When your levels tank, your risk for dangerous, irregular heart rhythms climbs. Calcium equilibrium dictates how well your blood vessels expand and contract, while vitamin B12 is indispensable for preventing vascular inflammation and maintaining nerve health. When you deplete these reserves over several years, you leave your cardiovascular system highly unprotected. Furthermore, growing clinical evidence indicates that long-term PPI therapies can directly impair the endothelium, the vital intercellular lining of your entire vascular network. When this lining degrades, your body loses its ability to properly regulate blood flow, manage clotting factors, and allow vessels to relax. Once again, this isn't a sudden shift. It accumulates silently over a long timeline, completely masked by the absence of overt symptoms. The primary mistake people make here is a failure of timeline management. A patient is frequently put on a PPI to heal a temporary issue, like a brief bout of severe reflux or mild gastric erosion. But because it works beautifully and carries a reputation for safety, the prescription simply gets renewed indefinitely. Nobody stops to reevaluate it. The longer that baseline usage stretches out without a formal clinical review, the more those hidden nutritional and vascular deficits compound. The remedy here isn't always an aggressive, immediate cessation. Often, the smartest path involves tapering the duration, looking into alternative therapies, or finding the absolute lowest effective dose. But those protective adjustments can only happen if you actively initiate the conversation. What we have analyzed so far is merely the baseline layer. Two everyday drug classes utilizing distinct pathways to quietly elevate cardiovascular strain over time. The next phase of our list cuts even deeper, moving past fluid volume and nutrient depletion to interact directly with cardiac mechanics, clotting dynamics, and how your entire system navigates acute physical stress. At this stage, the risks transition from subtle adjustments to much heavier physiological impacts. These next two classes don't just gently alter your blood pressure, they fundamentally reshape how your cardiovascular system reacts when it is pushed. Because these changes mature across months or years, they are incredibly easy for standard checkups to overlook. The third category covers medications widely turned to for insomnia, severe anxiety, or calming a hyperactive nervous system: benzodiazepines. This includes prominent medications like diazepam and lorazepam. They are undeniably effective at what they do. They blunt panic quickly and can induce sleep when nothing else works, making them feel like a crucial lifeline for many older adults facing life changes or sleep issues. But look at what is happening beneath that calming exterior. Benzodiazepines exert their power by dampening central nervous system activity. While that slows down racing thoughts, it also downregulates other essential bodily functions, including respiratory drive, physical reflexes, and spatial coordination. How does that translate to an elevated risk of a stroke or a cardiac event? The connection comes down to a behavioral chain reaction. As your body ages, its sensitivity to these sedatives intensifies. They accumulate in your tissues and linger far longer, meaning their sedating footprint expands even if your dosage remains identical. Over a long timeline, this persistent sedation inevitably leads to an increasingly sedentary lifestyle. Movement drops, and hours spent sitting or resting increase. That inactivity is devastating for your heart. Healthy circulation relies heavily on physical movement to pump blood back up to the heart. When you stop moving, blood flow stagnates. The statistical likelihood of deep vein clot formation rises, and systemic oxygenation drops away from optimal levels. Compounding this issue, benzodiazepines relax the muscles of the upper airway, which can severely worsen nighttime breathing disorders like sleep apnea. When your breathing becomes shallow and your oxygen saturation drops repeatedly throughout the night, your heart muscle is forced to work in a hypoxic, strained state for hours on end. This dangerous combination of sluggish circulation, nighttime oxygen drops, and an aging vascular system doesn't announce itself with sudden pain. It just feels like morning grogginess. It feels like low energy. It gets dismissed as just getting older. In reality, your cardiovascular system is running an invisible marathon under extreme duress, paving the way for a major vascular event down the line. The underlying hazard isn't the mere presence of the drug. It is the uninterrupted, multi-year use of a sedative while your aging brain and body become increasingly sensitive to its effects. That brings us directly to our fourth category, which introduces an intricate layer of danger, not necessarily due to what the drug achieves in isolation, but because of how it clashes with your existing medical ecosystem. Fourth on our list are systemic decongestants and stimulant-driven formulations. most notably products containing pseudoephedrine, along with various multi-symptom cold remedies. Because these are easily accessible right over the counter, the public naturally assumes they are entirely safe for anyone to use. However, their primary mechanism is remarkably aggressive. Decongestants clear out stuffed nasal passages by forcefully narrowing your blood vessels to reduce swelling. The catch is that this chemical message isn't targeted, it is systemic. It constricts blood vessels throughout your entire body, including the crucial coronary arteries supplying your heart. When your systemic vasculature constricts, your peripheral resistance shoots up. Blood pressure spikes, your heart rate accelerates, and the myocardium is forced to labor intensely to push blood through a narrowed, unyielding network of pipes. A young, highly elastic vascular system can typically absorb that temporary surge without lasting damage. But after 60, when your arterial walls are already rigid, that sudden chemical constriction can be profound, especially if you are already managing baseline hypertension or taking drugs that alter cardiac output. This is exactly how therapeutic crosstalk becomes dangerous. The vast majority of older adults are managing multiple issues at once. Perhaps a blood pressure pill, something for arthritis, a mild sleep aid, and then, the moment a seasonal cold hits, an over-the-counter decongestant gets stacked on top. In isolation, each chemical might seem manageable. Combined, they create a perfect physiological storm. One drug drives up pressure, another alters fluid retention, a third dampens circulatory efficiency, and your heart is caught in the middle, trying to compensate. When a medical emergency finally triggers, it always looks like a sudden, out-of-the-blue crisis. But in reality, the fuse has been burning for a very long time. The tragedy is that it was entirely predictable, a slow, cumulative compounding of cardiovascular stress that finally hit a breaking point. This is why personal education is your best defense. It allows you to spot these hidden pharmacological conflicts before they manifest as a crisis. That leaves us with our final medication. This one stands completely apart, not because it is rare or specialized, but because it is an absolute cornerstone of modern medicine, deeply trusted, taken by millions every day, and almost never viewed with a shred of suspicion. Yet past 60, its safety profile can flip on its head if it isn't monitored with extreme care. The fifth medication is low-dose aspirin. For decades, a daily, baby aspirin was championed as the ultimate, simple insurance policy for your heart. The conventional wisdom was straightforward. A tiny dose every morning would keep blood platelets slick, prevent arterial blockages, and ward off heart attacks and strokes. In specific clinical scenarios, that wisdom remains completely sound. If you have already survived a heart attack, endured a stroke, or have severe, documented arterial disease, daily aspirin is a proven lifesaver that keeps clots at bay. However, the scientific consensus has evolved dramatically. Modern, rigorous clinical trials have conclusively shown that for adults over 60 who do not have a documented history of cardiovascular disease, routine daily aspirin often fails to provide the protective benefits we once took for granted. Even worse, it can actively introduce severe new dangers. Let's look at the underlying mechanics. Aspirin works by permanently deactivating the stickiness of blood platelets, which effectively stops them from binding together to form a clot. But clotting isn't just a pathology, it is an essential survival mechanism. It is the only thing that stops you from bleeding out when an internal or external vessel suffers microdamage. As we cross into our 60s and 70s, our vascular walls naturally become more brittle. Our gastrointestinal lining grows thinner and more fragile, and the delicate scale balancing clotting against hemorrhage tips easily. When you artificially blunt your clotting cascade in this specific biological landscape, you dramatically elevate your statistical risk for major internal bleeding, particularly within the stomach lining or, most dangerously, inside the brain. This is where the ultimate medical paradox reveals itself. There are two entirely different categories of stroke. Ischemic strokes, which are caused by a clot blocking blood supply to the brain, and hemorrhagic strokes, which occur when a blood vessel ruptures and bleeds directly into brain tissue. While daily aspirin can reduce your risk of a clot-based stroke, it simultaneously raises your risk of a bleeding-based stroke. Once you pass 60, if you don't have an aggressive cardiovascular history to justify the trade-off, that statistical balance often flips. The risk of a life-threatening bleed begins to eclipse any theoretical protection against a clot. This is exactly why major international medical task forces completely overhauled their guidelines, actively advising against routine aspirin therapy for primary prevention in older adults. The widespread challenge we face today is that countless individuals initiated a daily aspirin habit a decade or two ago based on the outdated medical advice of that era, and they have simply kept going. They view it as a harmless health habit, completely unaware that medical science moved on while their body was changing beneath the surface. Aspirin isn't a bad drug. It is a highly specific tool. It must be precisely tailored to your unique current risk profile. Taking it just in case, without a clear, personalized mandate, is simply taking on significant bleeding risks with zero guaranteed reward. We have now broken down 5 distinct medications, each operating through vastly different biological pathways. Yet they all share an identical hazard. The risk spikes dramatically when the prescription remains completely static while your underlying biology is in a state of constant flux. This is where you can take back full control of your health journey. The takeaway here is never to panic and clear out your medicine cabinet. It is to realize exactly what needs a proactive medical review. Here is your checklist for making a practical difference. First, initiate regular, dedicated medication reviews. Don't wait for an adverse reaction or an emergency room visit to audit your prescriptions. Book a specific conversation with your doctor or pharmacist and ask the direct questions. Do I still require this specific molecule at this exact strength? Has my overall risk profile evolved since we started this? Is there a safer alternative available for my current age? Second, map your chemical combinations. The vast majority of the risks we've detailed today don't stem from a single pill acting alone. They are ignited by how multiple compounds interact. This includes over-the-counter remedies, sporadic allergy pills, and herbal supplements. Every single molecule counts toward your total cardiac workload. Third, develop an ear for your body's quiet feedback. Do not wait for crushing chest pain. Watch for subtle shifts. An uncharacteristic drop in your baseline energy, mild shortness of breath during a walk that used to be effortless, fleeting moments of lightheadedness when you stand up quickly, or minor drift in your home blood pressure logs. These are the subtle warning whispers that your chemical balance requires a fine-tuning. Finally, accept the beautiful reality that your body is a dynamic, evolving system. The fact that a specific treatment plan isn't a perfect fit anymore isn't a medical failure or a sign of poor health. It is simply the natural progression of human biology. The core truth of long-term wellness is simple. The true danger is almost never the molecule itself. The danger is matching a changing body with an unchanging routine. After 60, your system isn't just an older version of your 40-year-old self. Your metabolic clearance, vascular sensitivity, and stress tolerances have all transitioned to a new operational model, one that tolerates chemical imbalances far less easily. Small dosage mismatches and subtle drug interactions that you used to shake off can now produce significant systemic strain. This is a concept that is tragically underemphasized in modern medicine. Healthcare isn't a one-way street of constantly adding new therapies. Often, the absolute highest form of medical care lies in adjusting, reducing, or carefully removing treatments that no longer serve the body you live in today. When you adopt this mindset, it completely changes how you view your health. Medications stop looking like permanent, lifelong sentences and start looking like dynamic tools, instruments that must be calibrated precisely for the specific chapter of life you are navigating. When that calibration is exact, modern pharmaceuticals are absolute miracles of science. But when that calibration drifts out of sync with your age, that is precisely where the hidden risks begin to mount. At your very next checkup, try changing the entire trajectory of the conversation. Shift the focus away from merely reporting new complaints or accepting new prescriptions. Look at your provider and ask, is every single item on my current medication list still optimized for the person I am today? That single question transforms you from a passive consumer of medicine into an active, empowered manager of your own longevity. It shifts the entire clinical focus from reactive damage control to proactive optimization. Your body is constantly communicating with you through a quiet dialect of energy, sleep quality, and physical resilience. When you pair an attentiveness to those physical signals with a commitment to regular pharmaceutical reviews, you establish a level of protective control over your future that very few people ever manage to achieve. Ultimately, the dividing line between reacting to a cardiovascular crisis and preventing one entirely is almost always comprised of tiny, informed adjustments made long before a symptom ever appears. It is never about a single, dramatic lifestyle overhaul. It is about a continuous series of small, intelligent decisions that keep your internal environment perfectly balanced. You possess far more leverage over this process than you realize. You can't halt the calendar, but you have absolute control over your education, the questions you voice, and your commitment to ensuring your daily routine perfectly matches your current biology. That is what creates true safety. Not fear, not avoidance, but perfect alignment.